Okay, well, thank you. Last group, but not the least. I am going to show you guys the electrical impedance device. I don't think it's going to be amplified. It's just for the recording. I'll try to speak up for you guys. So what we're going to do, I'm going to show you guys basically the electrode placement on this device. We're going to go through a couple of alarming and specific applications on the device, and then we can have lots of time for discussion and questions. So I want to say on the outset, before we even look at anything on here, it's going to be not the same as what I showed you during my lecture. So the device that I have the most experience with in our unit and also in research is the 16 electrode array that is placed circumferentially around the chest, and then we basically look at an image that looks just like a CT or a MRI scan. So this device is not the same. We're not going to see the cool blue images that I showed you during my presentation. However, the manufacturers, for better or for worse, have decided to place the electrodes differently. And whereas the 16 electrode placement that I was previously using basically only images the lower portions of the lung. So we place it between the 5th and 6th intercostal space, which means the basal areas of the lung are what we're measuring, and the apices are completely ignored. We don't measure it at all in my laboratory. So what we do with this device, the manufacturers said, you know what, we don't care about the images. We care more about imaging at least a little bit every portion of the lung. So the electrode placement. Do you mind if we see the electrodes? So there's only 8 measurement electrodes. All right. Can you guys see? So there are 1, 2, 3, 4. So left, right, upper, lower. And then the middle one is a reference and or current injection. Okay? So if we had the belt on, it would be basically placed around here, and there would be 16, all in a nice little line. Oops, sorry, pal. Okay, thank you. So that's the principal difference. So what that means is that when we inject the current and measure it, it's going to be looking from front to back. That's the axis. Whereas before, I would inject here and then measure what comes out the other side on the exact same plane. So that's the principal difference. It's a different axis. The advantage, like I said, is now we can image a little bit in the upper lobes, but really the image looks like this. There's really no true image that I can show you on this device, but the closest analog is that there are 4 pixels. And so you guys all have smartphones, and so the number of pixels that you have on your phone is in like the thousands. So it's like 1440 by 720 or something like that. And so you have thousands of pixels. So the images that I showed you had 32 by 32. So these fancy medical devices already have a much lower resolution than we have on our iPhones. And on this device, there are really only 4 pixels. So for each region of the lung. So for right and left, upper and lower. 1, 2, 3, 4. Those are the 4 pixels. All right, so that's the biggest difference. If I had the Draeger device beside me, we would see the images simultaneously, but this is the device that we have to demonstrate this afternoon. Okay, that makes sense so far for you guys? So in terms of what's nice about this application is they have an alarming. So on the device that I use, there really are no alarms. So if you looked at market increases or decreases in ventilation to any one region, you never really know unless you just look at it. And for whatever reason, that's just what the software developers and the engineers did at Draeger. What's nice about this device is you can click on the image and set alarms. So it's a percentage. So what I just did was basically set the baseline. So as soon as I hit OK, it's going to be call this baseline. So it's going to call all those 0. And then any increases in ventilation or decreases in ventilation will be expressed as percentages in each one of those 4 quadrants. That makes sense? So I'm going to set these alarms for us just to demonstrate. So 50% below and 130% above. There, see how everything went to 0? Just briefly. And now you can see that relative to that time where I hit OK, there's a percentage increase in ventilation in the upper regions as well as a little bit of an increase in the lower regions. Okay? Yeah.
It represents that the child's breathing better in the upper part of the lungs comparing with the lower parts?
Yeah, so I wouldn't say necessarily better or worse, just different from where we hit that baseline. So as soon as I hit the OK button, it's just saying what's the change compared to that time point. So you could argue clinically whether or not that's good or bad, because if we have a fully inflated lung, we call that baseline, and all of a sudden we have more ventilation, well, that could be overdistension, and that would be bad. But consequently, you could have a snapshot or a baseline where it's just poor ventilation or poor aeration, and then any increase is always good. So I think that the steps that need to go between setting those numbers, interpreting the data, is really a clinical interpretation of what's going on with the mechanical ventilator as well. And I think that's probably the next important point is they actually do have a USB connection that I think connects to their commercially available devices. But the device we have, you can connect. I mean, everybody wants to just connect with their own. So a company makes a ventilator, they'll only make the EIT device work with their device because they want to sell you everything in one shot. But I will say that you cannot ignore the mechanical ventilator because it has most of the information about mechanics. This just has one additional piece that was forgotten. For example, if we wanted to look at the compliance of our subject, there could be changes in regional distribution of ventilation where the compliance doesn't change at all. And we could have the case where compliance changes a lot and regional distribution changes a whole lot as well. And those would mean two different clinical things. So in the case of a pneumothorax, for example, if you're on volume control, you're going to get, say we set it to just 100 mLs just to make the math easy. So if we set the volume guarantee or the volume control to 100, well, it doesn't matter if you have a pneumothorax, you're going to get 100 mLs of volume because the ventilator is going to do that. What we can see is one of these regions perhaps has a relative decrease in ventilation compared to an earlier time point, and that may be an early indicator earlier than the gross changes in compliance that we would note through mechanics or dynamic compliance on the conventional.
This indicate the green color circle?
Yeah.
Circles. So the bigger the circle, the better the ventilation, or does not correlate with the size of the circle?
I wouldn't say better or worse. I would just say more compared to earlier. That's what that means. And so really the green was just, I mean, this is their manufacturer. They just decided to represent the lungs like this. And basically, if you could see, zoomed in, you would see a blue circle and you would see a dashed blue line. And basically those two alarms that I set, an upper and lower threshold, are where those lines are. And as long as the ventilation is between those two percentages, then it's going to say it's green. And that doesn't mean better or worse. It just means within the range that you set. And then you decide clinically. I think the closest analog would be like a heart rate. So you have an expected heart rate of 80 beats per minute. And you would be okay clinically if it was between perhaps 60 and 100. Well, that's your decision, and you made that decision. And the alarm doesn't know what's good or bad. It just knows when it has breached that specific threshold. Because the case may be that 70 is bad for one child and okay for another child based on disease process, age, and stuff like that. So I think that's probably the closest analog. I will say that the machine that I'm used to, I think, has more flexibility in terms of analysis. Just because we're collecting a lot more data. The number of pixels, the image data that we're getting is a lot more robust. So I probably spent most of my time during my lecture convincing you that it's really important to look at this image, and even more important to look at region 4, the most gravity-dependent region. And that's because I think the physiology makes a little bit of sense in that your lung units, the alveoli in that case, are the most prone to collapse because they're basically under stress from all of the tissue above it. So if there's anything that's going to collapse, they're going to be the ones to go first. And what's unfortunate about that is all that tissue and stuff also means that a lot of the blood wants to go to that region as well. So if you have collapse and then a fair amount of blood flow, you have a pretty good shunt, and that means VQ mismatch, and you have to work hard to get good ventilation in that subject. So unfortunately, on this device, we can't do that same analysis, but it does let you look at just more global or rougher representations of impedance. I think the one thing that you could probably still do on this device is a PEEP titration. If you guys recall, I had one plot that basically looked like tidal ventilation. So it was got like the impedance on the horizontal axis, and then on the horizontal axis is the time, and then the vertical axis is the impedance. And you remember I showed you some tidal variation in impedance, and then all of a sudden we did a recruitment maneuver, and it went like this. and then we came back down to our older PEEP, and we looked at the difference between the baseline impedance at this time point after recruitment and before, and we said that if the impedance is higher, then it's probably an improvement in end expiratory lung pressure, or volume rather, and that's probably a good maneuver to have done. On this device, it's a little bit more awkward to interpret, but you can get to a similar process by using this plot here. So you can see that this is basically time, and this is impedance. And each one of these plots corresponds to one of the 4 regions of interest, one of the 4 quadrants, and they're all color-coded. So the white one is the upper right, lower right is yellow, upper left, lower left. So white, yellow, blue, purple. And so if you believe some of the literature, some of the stuff that I was telling you about the lower regions of the lung being more important, then I would probably argue that we want to look at the lower regions here, although that's not exactly region 4. It's all of them, 1, 2, 3, 4 altogether. It's just the difference between the apices and the basal regions. One thing that would probably be a reasonable experiment to do would be looking at the lower regions and looking at the change in baseline before and after recruitment maneuver or an increase in PEEP. Does that make sense? So for instance, we didn't really do this, but it kind of looks like perhaps we did. So we look at the baseline here with the lower lobe, left lower, and so we see the baseline is perhaps right around here. And then just imagine we did a recruitment maneuver here, and then we went back to that same PEEP, and now our baseline is elevated. Yeah, so we would say probably that our end expiratory lung volume has improved, and that was likely a positive response to the recruitment maneuver. But I admit it's a pretty rough, it's a little bit less intuitive, I think, on here to just interpret this with your eye, and also because it's not a global impedance, it's each 4, you're going to have to do a little bit of digging and a little bit of guesswork to get to what I showed you on that slide.
Stable condition that I have like a baseline, and then I can monitor any change in the rate. But
yeah.
I don't have this basal condition.
Yeah, I think that's a reasonable point. So really the question is, if you have a patient who you have basically good ventilation and then they get worse, that's probably an obvious application of having a nice baseline, and then you would see all these regions get into the red, and that would mean a decrease in ventilation in that region. I think that you could also make the argument the opposite way. And so if you had a patient who had really poor ventilation overall, you could call that a baseline, but now you're looking for a trend in the opposite direction. So you're looking for an improvement or an increase in ventilation across those quadrants. So it's really about the things that you'll see in the literature. The terminology is functional EIT, and really that's kind of what we're talking about. Is we're always looking at the relative changes in impedance and not the absolute number. And so we're really interested in like breath to breath and also over time what the changes are, because that's usually the trajectory of the patient that we're interested in and not the absolute number. And I told the last group as well, it would be awesome. On one of my slides, I showed you what the overall impedance was of a deflated and inflated lung. And so the impedance are measured in ohms. So 7 ohms was the absolute measure of a deflated lung, and then 23 when it was fully inflated. But it's not constant, yeah. So there's a lot of patient-to-patient variability among healthy subjects. So if we lined up a bunch of 8-year-old kids in a row who all looked the exact same, and we did pulmonary function testing, they all had the same FRC, well, we could apply EIT, and because they don't have a similar fluid status or the way their anatomy is fixed or different differences in perspiration and stuff like that, we could get different absolute measurements, but they could have all the same baseline. The thing that is the same between those patients, though, is the relative increase in impedance during tidal ventilation. So that's the functional changes that we typically rely on. And from a signal processing and bioengineering perspective, they chose that because it's easier to do, and there's less reliability in the absolute EIT. There are some researchers trying to get information from the absolute numbers, but thus far most of the published literature, especially on patients, has been functional EIT imaging.
Thank you.
Thank you.